Are there trials, for any of the panelists, are there trials looking at taxanes in this M0 space?
I'm not aware of any taxane currently NM-CRPC trials, no.
You know, there was a study that was done, sponsored by Sanofi, looking in the hormone-sensitive M0 space with intermittent ADT plus or minus taxanes. And it got stopped early, but it didn't really have a dramatic signal there. So, I think that there's some controversy as to whether or not it's as effective in this slower progressing population. But I think this really addresses the mechanism. That rapidly doubling time PSA is androgen receptor driven. Both of these drugs directly target that. And when you look at the PSA response, as fantastic as the metastasis-free survival results are, the PSA progression-free survivals are even more dramatic.
Right.
And it really suggests that it's an on-target biology that's driving this, and that these are the appropriate therapies if you're going to treat M0 castrate-resistant.
Yeah, and the overwhelming majority of the patients were very high performing in terms of their ECOG status. And I do think that additional patient-reported outcome data will demonstrate when patients see that their PSA has gone down so low, which we all know that's a concern, but maybe that's more subjective and anxiety-provoking, but nonetheless beneficial to a patient-reported outcome. But delaying other anti-neoplastic effects, and also more importantly, some of the Spartan data was very good at demonstrating a delay in symptomatic skeletal events. So there is this notion that you bring up. I think absolutely it's a risk-benefit discussion that has to occur with each patient. Clearly, somebody with a really slow doubling time, maybe and/or other comorbidities, maybe not the ideal person for sure. But as we know, as 80 becomes the new 60, and many patients will die of metastatic disease, especially if they have good actuarial survival. I think this data is compelling.
Phil, are there any abstracts that you know of or any trials looking at some of these newer biomolecular imaging techniques in this M0 space?
No, currently no. I think there's been some small animal studies looking at, I believe it was choline or fluciclovine in small mice that were castration resistant. I think moving forward, this is a hot topic. I think being able to use some of these advanced imaging tools as a biomarker to assess response is great. One of the strengths of PET-CT, which is what we're talking about today, is the fact that it's semi-quantitative. So we use FDG PET-CT all the time for a lot of other solid tumors and hematologic malignancies, and we could assess response. We look at metabolic activity. We can provide quantitative parameters and really tailor the care. So I think right now, this is sort of the baseline with regards to detecting METs, but the next stage is going to be how do we use imaging to help our referring physicians identify those patients who are responding versus those patients who aren't, and then figure out when we change. PSA is a great marker, but we all know that PSA doesn't always work. And I think this imaging tool could potentially lead to that. And there are some small trials, single site again, that are talking about treatment response, but we need to look at it more systematically at a higher level.
I think you make a great point, and I'm sure Dan would echo this, is that I think urologists get lulled into this whole PSA effect, and you can have lower PSAs and have progressive disease because we all know that there's so many resistance mechanisms that take out the androgen pathway, and so now all of a sudden, these are different genotypic tumors at this point. So
that's correct. That's correct. Although I'm going to be very interested in the maturation of this data. What we're looking at right now is really still kind of the early half of these outcomes. The medians are very unstable. Most of the events haven't hit the median yet. But when we follow this data out longer, we're going to see a tail. We're going to see potentially some patients that have no metastasis for 5, 7, 8 years, potentially. It'll be interesting to me if going forward in this population, there's a role for molecular imaging to help us identify who might be a long-term remission patient with a strategy like that. And I think that's going to be really helpful in understanding, are we just delaying this process for a couple years? Or is there a subset that we're really having a more indefinite effect on by using this really, I think, these are both drugs very unique in the field. These patients may have been exposed to bioclutamide or other drugs, but their tumors have never seen the kind of biology of this. And again, this is a different, phenotype, as we talked about, than the M1 castrate-resistant. So even though we don't necessarily see that many long-term responders there because of this heterogeneity that you refer to, there may be a more enriched subset here that get that. And that's going to encourage us to figure out, gee, how does that apply earlier?
That's an interesting point because, we talk about using advanced imaging at biochemical recurrence more often, and that's going to shrink the M0 space and make everyone M1. However, I think what it also might do is help us identify those who are truly M0. And those patients might be the ones who fall in that tail. So I think if we can work together and figure out how we incorporate imaging, that's exactly what we're going to do. And those patients who can really benefit from this with advanced imaging are probably going to have better results, even greater than 2 years MFS.